Good morning. I'm glad you all have your coffee because this will not be a stimulating topic of discussion, so you'll need the caffeine to help you stay awake during this. And I promise to be very brief. I also want to congratulate Brian on continuing to host this meeting. It's grown every year. I think this is the third or fourth time I've had the opportunity to speak here, and it gets bigger and better, and I'm impressed with what he does, not only in the operating room, but with the company and with Perfusion.com. So we will begin. I thought, unfortunately, I'm kind of the bearer of bad news regarding perfusion and transcatheter therapy interventions and what's going on. But I think it's important for you to understand where the technology is going and perhaps how you can collaborate with your surgeons and things that they can do or what things they should be looking for. And I think we don't have the answer yet, and that's going to be kind of the last slide. We don't have the answer, but let's figure out how we got there. So as she said, I'm from here in Fort Myers. I've worked with Brian for a long time, but there's 4 cardiac surgeons in our group. We do approximately 1,500 cardiothoracic procedures annually. And as you can imagine, that makes us all work a lot, including late at night, as last night is evidence. But we're very proud of what we've done here, and we are part of the Shipley Cardiothoracic Center, which is housed inside LeeHealth Park, and it's dedicated to research, innovation, and education. And we're excited about the future of that and where we're going. But pertinent to this talk is our transcatheter therapy program, and just as a brief summary, we were the first site in Florida, the second site nationally to perform a TAVR once it had been okayed by the FDA, and that occurred in November of 2011. The year prior to that, I had actually created a TAVR team, and we went to Germany and spent a week kind of learning the devices that were available. And quite frankly, in Germany at that time, there were several different devices, only 2 of which we see in the U.S. currently. But we saw how they did things, and even at that point in 2010, they had figured out how to do a fast pace and rapid procedure, rapid turnover system for their catheter-based therapy. So we came back with a lot of information, and then we had to sit and wait until the FDA approved U.S. trials to begin with the Edwards device. For the last 11 months, we have been in the top 10 in enrollment in the Medtronic FDA trial, which is that for low-risk patients, and I think we'll clarify that in just a minute. But there's non-native uses, or at least what I call non-native uses, not simply for aortic valve, native aortic valve processes or diseases. The devices are for aortic stenosis. That's the labeled indication. And the concern being that if you have simply insufficiency, you don't have the calcium burden to hold the valve in place, the FDA wasn't going to approve it, and quite frankly, lawyers in the U.S. wouldn't allow it. Were one to become dislodged, it would be a catastrophe in terms of legal issues. But so the primary indication is for aortic stenosis. The initial approval came through for extreme risk patients, followed then by intermediate risk, and now here we are later in the low risk trial, and we'll talk about that. But as I said, there's non-native evolution has begun. So now we have indications for placing these devices in failed prosthetic valves in the aortic position. Both companies have been allowed to do that, as well as in the mitral position, either an prior annuloplasty or a prior mitral valve prosthesis. For non-mitral prosthesis, it can be done off-label, and we've done a couple, and I'll show you an example of that in a minute. But you have to be very selective and very careful in those patients that you choose to use that. So our growth has been such that we're now doing approximately 5 to 7 transcatheter valve cases a week. We'll blow through 700 cases within the next couple weeks. all told. We've become more aggressive in using it in the mitral position, as I was just mentioning. So we're seeing a broadening of the indications for the device and how we can use it to the patient's benefit. Now, the excitement over this whole realm of therapy is really ridiculous. I have to say, these 6 devices that you see here, approximately 2.5 years ago, about $800 million was spent buying the intellectual property of these 6 devices by companies of various natures. That was based on a total human implant of 2 patients out of all of these, and a number of dog studies, and most of it was all theoretic, but nearly $800 million spent, and that happened over about a 2.5-month period. Once one company started buying what they thought was the best product, the other companies jumped in and did not want to get behind. So obviously, the medical device industry is well aware of where we are headed in the future, and again, where it ultimately ends up or lands, I can't tell you. I can tell you that these devices, most of them are not functional, but they're still under trial. The first in-human implant in an Edwards device occurred about a year ago, 1.5 years ago, I guess, and they have a trial underway for their device, mostly in Canada. There's about 5 centers in the U.S. currently that are working at it. The Medtronic has a device that they are working on. They've not yet implanted in their trials. They have some experience, I believe, in Europe with an implant, but I'm not exactly sure the outcomes or if that has occurred yet. I know they were planning it. So back to the history. March 2015, a Medtronic core valve for use in replacement of failed bioprosthetic valves. So that's was the first where they recognized that this was a potential. As you are all aware, there's a lot of folks running around out there with bioprosthetic valves that heretofore required redo surgery when they failed. And as you know, when we put those devices in younger patients, they fail earlier. So the average life expectancy of a bioprosthetic valve in somebody implanted less than 60 years of age is only about 8 to 10 years. Once you get over 70, you're getting longevity in the prosthesis, and that has to do with calcium metabolism and how the elderly manage their calcium and how it affects the valve. But we're getting out to 15 years of longevity in the valves once you're over 70. But nobody wants to take Coumadin, and so when given the option, frequently patients would say, I'll take that chance of a failed bioprosthetic valve and not be required to have daily Coumadin and all the issues that go with anticoagulation. So we do have a large patient population of, out there with bioprosthetic valves that are failing. Now, when the real critical question is, when we put a valve inside a valve, what have you created? Well, obviously you're not going to get the same dimensional size because you're constrained by what's already in place. You will improve the hemodynamics if it's truly stenotic. If it's a fail or a insufficiency, if they get a leaflet tear, you may not improve the gradients per se, but certainly you will improve the functionality of the valve. But how often can we do that? Can we do it 2 times, 3 times? And that's where the issue comes into the what we're facing now with our quote-unquote low-risk aortic valve protocols, is that younger patients are coming and saying, listen, I don't want a Coumadin issue. I'll take a bioprosthetic valve. And we go, okay, that's fine. We can perhaps do 1 valve-in-valve if size is reasonable. If we get a 27 aortic valve in, maybe we can get 2 valve-in-valves. But there is a limitation in how long and how frequently we can do this has not been answered. So we need to be very careful about offering still bioprosthetic valves in the very young patient, or at least they need to have an understanding that at some point they may come to a surgical event where they have to have a redo sternotomy and the full deal. we're going to run out of space. There's just not enough territory to put the valves in. But it really is an amazing development in terms of the way my practice has evolved. Most of the time now when I see a failed prosthetic valve, I'm thinking, okay, I'll treat this with a catheter and not have to open them. So it has really opened up the armamentarium that I have available. MitraClip is something else that's, again, kind of the intermediate answer between full surgical replacement or repair of a valve versus medical therapy. Severe mitral regurgitation is a terrible disease. Once you develop heart failure as a consequence of mitral regurgitation, you have about a 50% one-year mortality. And that's in the best of hands. So we are very aware that most of those patients do require surgical intervention or some sort of intervention to try and reduce the effects of regurgitation. And it's a self-fulfilling thing. You get regurgitation, you get ventricular dilatation. That results in remodeling of the heart, restructuring of the muscle, realignment of the myocytes, and then dilation again of the annulus begets more regurgitation, and the cycle goes on and on. And as I said, about a 50% mortality in severe mitral regurgitation that's not treated. So the MitraClip plays a role, and a significant role. It's very user-friendly, if you will. It's done through a transvenous approach, but there are some caveats. You need to have a mitral annulus that's big enough to allow us to reduce the outflow or the effective area of the mitral valve. So we try to start with at least greater than 4 centimeters squared area of the mitral area. We need minimal calcification in the grasping portion of the leaflets of concern. We don't want clefts in the leaflets. Frequently we see clefts in mitral valves that account for the regurgitation. It's not the leaflet itself, it's the gap within the leaflet. So in a P1 or P2 or P3 segment, if you have a cleft, we can't grasp that with the current technology we have. What we can do is put an anterior leaflet to a posterior leaflet. We can grasp those two things, seal them in essence you end up with a double barrel orifice of the mitral valve as opposed to a large single orifice. And so that's where it comes back to having enough area to allow clip application and the anatomy to allow it. So if there's a big gap between the leaflets of greater than 15 millimeters, you're not going to be able to get it with the current technology. Or if there's an overlap of greater than 10 millimeters, you're not going to be able to grasp, successfully grasp, at least predictably grasp. Now, MitraClip currently, the only device available is an Abbott device, and they have changes coming. They're lengthening the arms of the clip to allow us to grasp farther out into leaflets and perhaps thicker leaflets and a wider grasp. It potentially could be done to close a cleft if we get sophisticated enough, but we are not there yet. So moving towards less invasive approaches to these problems has allowed my interaction with perfusion to become less frequent, and I think that's a detriment to both of us, both sides of the table. And we don't know why or where we're going to end up. But with our low-risk trials, we're now treating patients that have normal ventricles but have severe aortic stenosis. And so how often, based on our current technologies, do I need to go on pump? Well, it's almost never. When we first started the trials, our first experience with aortic valve replacement with catheter valves, we were doing the exceedingly high-risk patients. And those patients had terrible ventricles. They had a lot of comorbid issues that put them into that category to begin with. So we definitely needed perfusion standby. We were putting in balloon pumps to help stabilize the patients, and we were not infrequently having to go on bypass to complete the procedure or whatever. And there was some hybrid utilization where we actually did bypass, put the device in, and then went off pump, but we didn't have to open the chest, but we allowed support. And I think being aggressive and thinking out of the box, there's still going to be a role for that interaction between perfusion and surgeon, but now we're approaching some of these things with the newer devices. They're lower profile, they're more predictable in terms of when you place a valve, it stays where you place it. We don't have as frequently the wire penetrations of the ventricle. We're not rupturing annuluses that could occur in the initial trials. We're understanding the dynamics of both the device and the interaction with the patient's anatomy. And that includes the aortic annulus, the mitral annulus, et cetera. So I can't say where we're going to end up with this, but we individualize our current protocols. Now we're individualizing our standby processes so that we look at every patient in terms of comorbidities, expectations, and things that we think may contribute to a successful implant, and how much protection or insurance do I need to buy for the patient in terms of standby for perfusion. I will say a lot of this is economically driven. If you are employed by the hospital on strictly a contract, then, and not a per case basis, then they don't necessarily care if perfusion is on standby. They do care if we're opening up tubing and priming a pump and that sort of thing. But if you're being paid per case basis, the bean counters are looking at us and being very critical because of, one, the expense of the devices, and two, the turnover of the devices and how infrequently we're using them. So there's been a lot of pushback from the financial side of hospital systems to minimize resources in terms of how much we expend on each patient. The average length of stay in our aortic valves has now come down to 2.5 days post-implant. We're not infrequently sending patients out the next day after I put an aortic valve in, which is, you all know, is a real shift in patient care. For those patients that go home the next day, they have to have a very tight QRS, no evidence of bundle branch or any change in conduction as a consequence of having this valve put in that's exerting a huge amount of radial force out against the bundle. But that being said, we are becoming more sophisticated in our implant techniques, and we know what to look for in the EKG, so it's not uncommon now to send a patient home within 48 hours and even 24 hours after having an aortic valve replaced. Our MitraClip patients generally go home the next day. Our statistics currently say 3 days on average. Most of that is because some of these patients are extremely ill to begin with, and we are consulted only kind of as a last resort. So they stay in the hospital, get their kidneys tuned up, pulmonary functions improved, et cetera. But again, a successful MitraClip implant, the patient, when they wake up, and we do those under general anesthesia because it's all guided by TEE, and to spend a couple hours with a TEE probe in, patients don't tolerate awake, so they're all intubated. But when they do get extubated, they will almost always say, I can tell a difference, I feel better. So the reduction in mitral regurgitation with the MitraClip is an immediate benefit that they all note. On the aortic side, most people feel better. They don't know it right away. When we first started, you could see on the echoes a sick heart. Again, these were extreme risk patients with severe reduction in ejection fraction. We put a valve in, and immediately the heart got better. And we obviously, as a surgeon that was opening aortas and on pump, and we had all the additional insult to the myocardium from being on pump and cardioplegia, I never really recognized immediately how much better the heart gets. So doing them without perfusion, without anything else, and just giving them a wide open aortic valve as opposed to a stenotic valve, the hearts immediately get happier, and it really is a dramatic change in what the echo looks like in most people. So this is a video, typical patient aortic valve-in-valve that we've done, and I apologize for this video ahead of time. You see the 3 circle markers? Do we have a... Is this a pointer as well?
Yeah, the top one is a pointer.
Okay. If you can see these 3, we'll go back. These 3 markers represent the top post of an Edwards valve. And interesting, the Edwards valve lends itself to this exceedingly well. This is a Medtronic core valve being placed inside of this old Edwards prosthesis. And what we have realized that if we put a balloon in here, and I talk about here, but if we blow the balloon up to about 20 atmospheres, we actually fracture the frame of the Edwards valve. And we've been part of a national study. We presented it at the STS this last January. But we can take an old Edwards Paramount and then actually fracture it and reduce the gradients. And in this case, we took the gradient initially was 119 millimeters of mercury in the failed stenosed valve. When we implanted without balloon dilatation, we had taken that from 119 to 17 millimeter gradient, which is certainly acceptable in this case, but we thought we could do better. So we put in a true balloon, blew it up to 20 atmospheres, fractured it, and we got the gradient to 7 millimeters, which is about almost a normal human gradient. And this patient has done exceedingly well. As you can see, had a complicated history, had 99, had a homograft, and subsequently redo surgery, and I put this valve in, and then actually it says Mosaic, but it was an Edwards. And the patient is resumed. He lives on a island off of Canada and is about as far away from medical care as you can be, and he's exceedingly grateful and has done well. This is a case of Sapien valve-in-valve in the mitral position, and you'll note the approach here is with transvenous. So we cross the septum, get it in position. And again, these valves, the Sapien valve has to be done with rapid pacing. So there's some hemodynamic compromise. We don't want while you've got this balloon up, we don't want the heart ejecting to dislodge the prosthesis as you're putting it into place. So it's a simple thing and really works well in the mitral position. Now this is mislabeled again, and I apologize. It says patient with a Sapien 3 in the aortic position. Actually, I put this is a very kind of gratifying and illuminating patient. She came in with severe pulmonary hypertension and had prior annuloplasty of the mitral valve. Was thought to have mitral stenosis and regurgitation. Couldn't get her off her drips, any support whatsoever, a balloon pump in. So we took her to the cath lab with the intent of doing a mitral valve-in-valve prosthesis. We did that. As you can see, it's a Sapien. We got it in and went great. But then once we'd eliminated her mitral pathology, we recognized how bad her aortic stenosis was. So in the same setting, and we did not have CT studies on her. She'd been too sick to go to CT, and nobody had recognized how bad the aortic was. But once we got this open, we saw, oh, this is not acceptable. So based on echo alone and hemodynamic findings, we went ahead and put a Sapien in the aortic position, which is the one you see being inflated here. So now she's got 2 valves and functioning perfectly. She was morbidly obese, as I said, and as my pointer is not really working, but these are almost kissing, and the bundle runs right between them. The bundle of His. So we had a temporary pacer in her. My mistake was not making it an active fixation pacer. And the next day, the nurses got her up and were trying to get her into the chair. She was extubated. She hadn't been extubated for several days. And the pacer dislodged. She arrested. We couldn't get her back. And she ended up dying after what was a perfect outcome for her. So that was a lesson well learned. Anytime there's an issue regarding pacer and stability, we go to active fixation leads, particularly if we want to get them up and move them around. So unfortunately, we learned it the hard way. This is a case of a native valve with severe MAC. If you can see, I apologize, my pointer is not doing the job. But in the left picture, you can see the calcium to the right of the wires. That's her native mitral annulus, and that's just a rock. There was no way surgically, this was going to be a redo procedure. She'd had prior cabbage. So we said, okay, we can do better than that. We'll put go transapical and put a mitral prosthesis in, which we did. It worked exceedingly well. And here's the learning part of mitral pathology and mitral anatomy is that once we got that valve in, again, we're not relocating the anterior leaflet of the mitral valve as we do in surgery. So what we had done is simply push this up, and she had a very significant septal bulge. The interventricular septum was very thick. It had a bulge, so now we've pushed the anterior leaflet of the mitral valve up into the aortic outflow tract. And it took us several days to really recognize what was going on. And again, she wasn't an operative candidate traditionally to begin with. And so we debated whether to stick in a Medtronic valve and bury it deeper into the outflow tract to try and lift the leaflet away. We were discussing it with the family, and they finally said no, they didn't want anything else done, and she didn't want to go back to the operating room. So she ultimately died of low output with a normal ventricle. She had an EF of 60%. And it took us a couple days to recognize what we had done and why it was failing. But now we look at leaflet length and we look at septal bulge, and so we have to be very careful. Not everybody can have this procedure in the native position because you may compromise LVOT if in fact there is that combination of factors. So again, it's lesson learned as we progress through our process of advancing with these technologies. This is what it looks like. This is that lady that had two prostheses, and this is the mitral after implant. And you can see that open on echo. It's wide open, and what it looked like before was this rock. So it really is a dramatic change that you see immediately. And again, our echo technology has become so advanced. We're getting a lot smarter about what we're seeing and what to look for in these patients as we go down through the stepwise assessment of each and every patient. Again, this is just showing prosthetic valve, the mitral position working exceedingly well after implant. And then this was done, I think, transeptally. So where we are, we need to continue to progress. Obviously, that's the name of the game. We are getting better. I think we're going to move toward hybrid type procedures where we use transcatheter valves in combination with PCI. So the traditional aortic valve coronary bypass graft combination may not be as frequent as it is currently. There is a trial underway now comparing mid-cab to PCI, mid-cab being minimally invasive, single vessel off pump, mammary to LAD versus PCI, and that's being done through the National Institutes of Health. We're a part of that trial as well. They are going to collect 2,000 patients, I believe, is their intent. And So that's really just underway. I think they've only enrolled 60 or 70 patients thus far. We've got a couple enrolled. So where we are, where we're going, I wish I could tell you. It is becoming, the devices are becoming smaller, they're becoming more user-friendly. Our cardiology colleagues have absconded with some of this and taken it directly to the cath lab, and in some institutions are not even involving surgeons, probably not involving perfusion. We've maintained that it is a disease that is multifactorial. It requires the input of both cardiology and surgery. I believe, and at least in our institution, will never compromise on that. The surgeons are always going to be involved, and I believe with collaboration with perfusion and with the help of the cardiologist, we will continue that way and provide the best care to the patients. One comment I was going to make, when we do stand by some of these access issues, we've got cannulas in the apex of the left ventricle, and there was one occasion where we actually had planned, if we were going to go on bypass, we were going to use that transapical cannula as our inflow. Fortunately, we didn't need to do it, but we had perfusion standby. So there are things you have to think about, and you have to be ready, because most of these patients have issues that transcend our traditional thought process. I would be happy to entertain any questions. Otherwise, I will let you resume your morning.